Okay, welcome everyone. Thank you for coming to this session, Major 10. Welcome to everyone who's joining us online as well. We welcome your questions. Sorry if I'm sounding a bit breathless, it's because I've got altitude sickness. I'm not just about to pass out, don't worry. So I'm here running a session. We're here running a session called Harm Reduction and Cocaine Use, Decolonization, Intervention Strategies, and Scalable Solutions. My name is Matt Southwell. I was part of writing the UNODC, UNAIDS, and WHO guidelines on stimulants which we've been rolling out around the world. And one of our very key collaborators in that process was Ernesto Cortes. Ernesto is one of the founding members of the Latin American network of people who use drugs. Also works at the University of Costa Rica, and he's going to talk. And he's been just a key champion for this region and understanding issues for producer countries. So I just really want to, in a public forum, big up Ernesto for being such a champion in all the UN processes to make sure that we don't forget Latin America and issues of smokable cocaine rather than injecting. So thank you, Ernesto. So Ernesto is going to talk to us about crack and Basuco pipes in Latin America, smokable cocaine, harm reduction, and decolonization.
Thank you, gracias. Voy a hacer esta presentación en español. I'm going to make this presentation in Spanish. It's in inglés. Sorry, tengo que... No, la fiesta estuvo intensa ayer. Entonces, bueno, pipas de crack y Basuco, de cocaína fumable, reducción de daños y decolonización. Voy a tratar de hacer un proceso. Vengo trabajando este tema hace unos cuantos años. Hemos hecho revisión de literatura y de información en la región, la cual es muy poca. Realmente, a pesar de que el uso de la cocaína fumable en la región inició desde la década de los 90, sigue habiendo poca información. Entonces, esta es una serie de estudios que se han publicado en la región, en Argentina, en Uruguay, especialmente Brasil. Definitivamente Brasil es el país con más investigación, pesquisa y programas también de reducción de daños que trataré de mencionar, si me da tiempo, la presentación. El último, a ver si tengo un pointer acá, el último estudio, esta presentación se basa en ese estudio especialmente, es un estudio que publicamos en 2019 con el Transnational Institute de Holanda, con Pink Metal, que es una buena amiga. Y les podría decir que pensé que después de publicar ese estudio iban a llover las oportunidades de seguir haciendo investigación en cocaína fumable. Ya estamos en el 2025 y sigo presentando lo mismo una y otra vez. Pero entonces, una de las cosas que quiero mostrar en este mapa, este es un mapa de tráfico internacional de cocaína, es especialmente esta región que vemos aquí marcada, Colombia, Perú, Bolivia. Son los países de producción de cocaína, los únicos países de producción de cocaína, ¿no? Y eso hace una gran diferencia para entender las cocaínas fumables, ¿verdad? En los países de producción hay Basuco, hay pasta base principalmente. En los países de tránsito, o sea, el resto del mundo, lo que tenemos es crack. Entonces, este es un proceso, un esquema de producción de cocaína. No voy a tardarme mucho en eso, lo que me interesa es que vean principalmente las flechas. Esas flechas en el proceso de producción cocaína son productos o subproductos que son fumables, ¿no? La cocaína como clorhidrato es un ácido, no es, o sea, se puede fumar, pero el efecto es muy bajo. De hecho, yo no recomendaría a las personas usuarios de cocaína que la fumen, ¿no? Si la van a fumar, pues conviértanla en crack, ¿no? Que es un proceso al final. Finalmente, bueno, incluso aquí en Colombia al crack le llaman patraciado, ¿no? Es devolverlo a la base, ¿no? Porque esa es la diferencia. Lo que se fuma es una base. Y entonces estas son imágenes distintas de Brasil, Costa Rica, México, Colombia, este me lo pasaron de Perú, ¿no? Un poco para diferenciar cómo se ven. Podría haber puesto, no sé, 30 imágenes más y vamos a ver muchas diferencias, ¿no? Finalmente es una sustancia que cambia mucho que está muy adulterada y, como vamos a ver, está muy asociada a ciertas poblaciones. Poblaciones empobrecidas, poblaciones marginadas, ¿no? Y no es la sustancia la que hace eso, ¿no? Es una situación, un contexto cultural y político y social que asigna esa sustancia a una población específica. Las formas de fumado en América Latina varían mucho, ¿no? Mientras que vemos como cachimbos más en Brasil, o pipas de Basuco, tubos de metal que se usan mucho en Costa Rica, donde vengo, el fumado en lata, en fin, ¿no? Y esto es clave para entender por qué hablamos de pipas de Basuco y crack, ¿no? No solo la sustancia, sino también la parafernalia que se crea o es creada por las personas usuarias cambia, y eso hay que entenderlo. Esta foto, que es de Levinson Niño, que está por ahí atrás, un compañero que nos unió las cocaínas fumables, es una obra de arte, ¿no? Es estas habilidades para crear estos instrumentos para especialmente fumar bazuco o pasta base, ¿no? Eso yo no lo veo en mi país, no lo vemos en Brasil tampoco, ¿no? Así de nivel de elaboración, y pues ese proceso, ¿no? Lleva incluso una moneda pegada acá, ¿verdad? Todo el instrumento, incluso se puede quedar ahí de pie en la mesa, y eso, digamos, hay que entenderlo. Es indispensable entender cómo las mismas personas usuarias crean estos aparatos o esta parafernalia, ¿no? Y de ahí producir herramientas que sean funcionales. Aún así, la cantidad de recursos o de parafernalia que he encontrado en la investigación que hicimos o que encontramos es muy reducida. Incluso lo que vemos aquí arriba, ahí ya vi que María Angélica lo reconoció, es una de las herramientas o kits que entrega HLA o entregaba HLA, es una organización en Sao Paulo, en la zona de Cracolandia, porque ya había un mercado de cachimbos, ¿no? Ya hacer una pipa era innecesario, porque ya estaban estas pipas que se vendían en el mercado. Entonces, sencillamente lo que entregaban eran estas boquillas de hule o mangueritas, ¿no? Y una mantequita de cacao, un lip balm, ¿verdad? Para las personas. Mientras que en México, en Ciudad de México, hace años, un proyecto financiado por la fundación de Bill Gates, entregaba todo un kit, ¿no? Lo interesante de este kit, si vemos, es que es muy similar como a este otro. Estas pipas de Pyrex, ¿verdad? Una versión más al norte global, si queremos decir, fueron inefectivos. De hecho, las personas usuarias dijeron que no les gustaba, que eran muy grandes, que los pedazos de crack para poner en la pipa no quedaban bien, en fin. Y además, como la Fundación Bill Gates trabaja temas de VIH, no encontraron una disminución en la transmisión de VIH porque hay muy poca riesgo de transmisión por la vía fumada, ¿no? De hecho, hay algunas investigaciones que demuestran algún riesgo de transmisión de hepatitis C, pero bueno, ese es una de las situaciones y de los problemas que encontramos y que me voy a referir un poco más adelante, también porque no hay tantas estrategias de reducción de daños, porque casi no hay financiamiento para esto, ¿no? Es claro, el VIH es lo que ha movilizado la reducción de daños a nivel internacional. El Fondo Mundial, el Global Fund, ¿no? De VIH, malaria y tuberculosis, es el principal financiador a nivel internacional, y tiene que haber una evidencia, ¿no? De que hay un riesgo de transmisión, como claramente lo hay con el uso inyectado. Entonces, pero bueno, esta otra pipa que ven acá, este fue un modelo que se hizo aquí en Bogotá, con silicón, y si ven, todo se divide y todas las partes se separan, porque una también de las prácticas que hacen las personas usuarias de crack es sacar todos los restos, ¿no? En Costa Rica le llaman las alitas de cucaracha, me acuerdo teníamos nombres para todos los países, ahí me podrían decir Brasil o en Colombia. Entonces, parte importante también para las personas usuarias es reutilizar todo eso. Aunque no se recomienda, pues es una práctica cultural. Pero lo que me interesa principalmente, ¿verdad? Más allá de estos kits, que estos kits, me devuelvo un segundo, claramente previenen los riesgos de daños a la boca, a la lengua, a la garganta, ¿no? Si vemos, me devuelvo de nuevo, los tipos de pipas y las alambrinas y todo son metales pesados o partes de metal que caen en la lengua, que caen en la garganta, te queman, ¿no? Al igual que dañan el sistema respiratorio. Esto previene, ¿no? Este tipo de kits previene eso, ¿no? Pero finalmente son solo una herramienta para acercar a las personas a los servicios, ¿no? Y si pensamos en las personas usuarias de crack, aquí quiero poner 2 ejemplos. Esto es el Bronx arriba, Cracolandia abajo, en Sao Paulo, ¿no? Que son 2 ejemplos, bueno, el antiguo Bronx, ¿no? Y el Cracolandia, que mueven de un lado para otro, ¿verdad? Donde se desarrollaron proyectos en ambos países dirigidos a estas poblaciones, porque como dije, son poblaciones que históricamente y cultural y hasta sociopolíticamente se han excluido y se han marginado. Entonces aquí en Bogotá, hace muchos años, cuando el presidente Petro era alcalde de Bogotá, desarrolló los CAMATs, que eran ¿cómo era? Centros de Atención Móvil a la Drogadicción. Perdón, ya son muchos años y repitiendo lo mismo. Lo importante es estas vans, ¿no? Con servicio de atención médica, servicio de atención odontológica, ¿no? Porque el tema de los daños a la boca, a los dientes, todo es clave, ¿no? Y principalmente equipos interdisciplinarios, médicos, trabajadores sociales, psicólogos, en fin, ¿no? De hecho, esto viene mucho de los consultorios Narrúa, que es una estrategia que en Brasil lleva mucho tiempo y les recomiendo buscar, ¿verdad? Son los consultorios de calle. Perdón, ahí no sé si el Wordly va a traducir a portugués. Esta señora de aquí, por ejemplo, era la gestora comunitaria. O sea, es una persona de la comunidad que está ahí. Porque eso es clave también. Si queremos que las personas se acerquen a los servicios, especialmente personas excluidas y marginadas, necesitamos personas de la comunidad, necesitamos personas pares, ¿verdad? Usuarias de drogas, ojalá, pero que tengan esa capacidad. Y el otro ejemplo que quiero poner es de Brazos Abiertos en Sao Paulo. Yo tuve el privilegio y la dicha de poder estar aquí en Bogotá en 2015, ir a ver los CAMATs del Bronx, Liberia, Colabastos, el de la cárcel, proyectos impresionantes. Y tuve la dicha también de poder ir a ver de Brazos Abiertos con María Angélica, que está allá, Tica, que está por acá, y ver el flujo, ¿no? Todo el espacio de consumo, pero también este proyecto, que era un proyecto enorme. Eran cerca de 13 secretarías municipales, no sé cuántas estaduales, ¿verdad? Era el gobierno entero alquilando hoteles completos para que las personas en calle tuvieran un lugar donde dormir, brindando opciones de trabajo diarias, por lo menos 13, 15 opciones diarias donde las personas iban, trabajaban, les pagaban en cash, ¿verdad? Que si iban a comprar crack con eso, es su dinero, ¿no? Ambos programas fueron evaluados exitosamente. 1 minute. All right, I'm just run. El punto es que en 2016 aquí en Bogotá, 2017 en Sao Paulo, hubo cambio de gobierno, pues lo primero que hicieron fue una intervención policial o militar, ¿verdad? Estos programas desaparecieron, ¿no? Bueno, no sé si queda en algún hotel por ahí en Brazos Abiertos o en Sao Paulo, pero son programas evaluados con inversión estatal, ¿no? Y digo todo esto porque finalmente las personas usuarias de crack son muy estigmatizadas, ¿no? La mayoría de estas campañas de comunicación no son muy viejas. De hecho, esta de Brasil es de hace unos años con el gobierno de Bolsonaro, este es de hace como 2 o 3 años con el gobierno de López Obrador, ¿verdad? Ahí vemos el Basuco es el diablo. Entonces, cuando hablamos de pipas, ¿no? De crack, le puse como una intención, finalmente hablamos de personas usuarias de pasta base, de crack o Basuco, ¿no? Y si queremos hablar de reducción de daños en América Latina, en un enfoque colonial, tenemos que ir más allá de la pipa. Repito, es un instrumento, ¿no? Es una forma de acercar a las personas, ¿no? De mostrarles una forma menos dañina de consumir la sustancia, ¿verdad? Pero de que puedan acercarse a los servicios, ¿no? Comenzar en redes de atención Y por eso, voy a ir muy rápido en eso, incluso les voy a decir en inglés, incidencia política, advocacy, ¿no? Participation, necesitamos a las personas usuarias de drogas ahí, necesitamos trabajar sus derechos humanos, territorialidad, trabajamos en el territorio, ¿no? ¿Vieron estas fotos? Ahí yo veo a Tika, esto era de LA, cuando estaba en el edificio aquel que nos llevaron. Esto es Redes de Amaré, Enrique, que pude estar también en Sao Paulo viendo un proyecto similar. Persona de las comunidades trabajando con su comunidad, ¿no? Y por eso el último trabajo en redes, networking. Es indispensable conectar con otros servicios. Y finalmente aquí también en portugués, que esto se lo robé también a los compas de Delay, porque para mí realmente Colombia y Brasil son los mejores ejemplos de eso. Nos dicen cómo la reducción de daños va más allá de la sustancia, ¿no? Se trabaja a partir de las personas, es un proceso continuo, ¿no? Hablamos de derechos humanos, de la continuidad. Y pensando cómo la reducción de daños en América Latina viene más desde un tema de educación popular, de investigación, acción participativa, salud colectiva, teología de la liberación, si queremos, cómo los objetivos van, es mejorar la condición de vida, no tanto prevenir la transmisión de enfermedades, se abordan los riesgos, pero también las desigualdades. Trabajamos desde un compromiso político, desde una ética de cuidado. Me encanta, pues eso también en Brasil, ¿no? Cuando uno piensa en reducción de daños, muchas personas me han reducido una ética de cuidado. Cuidado personal, cuidado de la otra persona, cuidado del planeta en general, ¿verdad? Estamos destruyendo el planeta. Y apología a los derechos humanos, es partir desde ahí. Entonces, la reflexión básicamente, y thank you, Matt, for the time. Gracias. Es un poco esto, ¿no? Si hablamos de decolonialidad, si hablamos de reducción de daños en América Latina, es ver estas realidades, es ir más allá de la parafernalia, no de los instrumentos que sí son necesarios, y por eso así le puse de título a mi presentación, porque seguimos sin tener estas herramientas en los programas de reducción de daños o de atención a poblaciones vulnerables, pero en realidad es entender que es un tema de político, de compromiso político y de derechos humanos. Y I'm done. Gracias.
Thank you so much. Sorry, I was getting a little confused between trying to read something and watch the timing at the same time. So you did great with timing. I just did a bit badly at chairing. That was the different thing. Okay, so let's. We now have the pleasure to listen to Sacha. So Sacha, hang on, where am I? Wrong person. Let me read the right person. Would be great. Oh God, it's the wrong session. That's why. So anyway, let me introduce Sacha just from memory. So Sacha has been involved in the Fédération d'Addiction in France, which works around harm reduction and addiction, has been particularly involved in innovation around harm reduction and harm reduction technology. France has particular issues around crack cocaine and has been doing a lot of innovation. So we're really happy to hear you speak, Sacha, today.
Should go? Yeah. Can I have the... Yes. Thank you very much. And continue and Contingency organization support over the last 4 days. So we speak in English. Questions how to cook crack one, the making of a harm reduction body, to bake in English. So first, what is Fédération d'Addiction? As we said, Matt, we are a network of organizations professional in the field of addictions, and our ambition is to fight the stigmatization of people who use drugs by working with them and to develop solutions tailored to their needs and working with a professional in the field of harm reduction and addiction. Before starting the presentation, I did not do this project alone, so I wanted to thank all the people involved. So Leon Gamberov and Georges Slon, who co-coordinated the project, some harm reduction centers who are very involved, the GRADE, EGO and Spiritech in north of France, the psychoactive.org forum, who had very good insight and were very vigilant about the video and the content of the video. It's a forum of people who use drugs. The Belgian association Modus Vivendi, who allowed for great Belgian and French collaboration, I will talk about it later. And finally, the French Phone Addiction, who funded the project, Epoch, in which the video was produced. So crack cocaine and base cocaine, just to give the context in France. In France, we use crack for a very specific thing, which is the crack sold as crack on the street and not as a powder. And it's almost only in Paris, in the open scene of Paris. And it's directed at very marginalized population, very oppressed and subjected to violence, police violence population, and mostly people of color. While cocaine basé, so base cocaine, is more present in the rest of France. So it's homemade with powder cocaine. It's cooked by people, also marginalized population, but maybe more diverse and with less operations. So quickly, but I guess you know it, what's crack cocaine? It's cocaine, the salt, with baking soda or ammonia. You put some water on it, you put some heat, and you get crack. If you need more information, we did the videos about it, and you can have them if you want. So there are two ways of making crack in France, at least, I don't know, in other places, with ammonia and baking soda. So you might have guessed ammonia sounds way healthy than less healthy than baking soda, but both have pros and cons. So for ammonia, it's very easy to cook with, very fast, gets like 1 minute, and it gives you a hit in the throat that some people really like. But the cons, it can damage your lungs more than with baking soda. There's a risk of ingesting it, thinking it's water when you wake up in the middle of the night, and a risk if it comes in contact with wounds. That can happen when you smoke crack. And for baking soda, it's less risky for health, less risks of ingesting and things like that, but you need more skill to cook it. It's like a bit longer, and you don't get the heat. So what we can learn from that is that baking soda is better for health, but some people prefer ammonia. And it's very important when we try to do harm reduction and support people to know what they prefer and what they want. So I will give a story of this because it's important to see how it was made. With every fashion project, it comes with demand from our network. And there was from the network about tools to support people who smoke crack because they saw a very steep price of people smoking crack in the harm reduction center, and they didn't feel that the capacity to support them well. So we applied for a project with the government, and we got funding for the Epoch project, which was aiming at strengthening practices to people who work with people who use cocaine. And when we start a project, the first thing we do is to see what's happening already, not do the same thing twice. And we heard that in the north of France, a structure developed protocol, a crack cooking workshop with people who use crack to teach them, see them how they cook from ammonia to baking soda. And that's our inspiration. And from that, we were looking at ways to make this one example scalable and available for everyone in the country. And the idea was to make videos based on that protocol. So the second thing we always do is a working group with all the people involved, so experts, scientists, harm reduction worker, of course, people with drug, to write a script of the video. And the first thing we learned that we don't need one video on baking soda, but we need 2 videos on ammonia, because there are ways of reducing harm when you cook with ammonia. And if we didn't make this video, some people would just say, I don't want to cook with baking soda, and I don't want to work with you on my practices, and we would have lost any chance of reducing harm. So we needed to do the 2 videos. And just after that, I went to a conference like this. It was in Zurich, and I met with a Belgian association, Modus Vivendi, and we talked and found out that we both had the exact same project. So instead of saying we'll do one French and one Belgian, because we both speak French, we can pool our capacity, pool our resources, and do one project together. So we made the first video, how to crack one. We are very happy about it. Then we tested it with people with drugs and harm reduction workers, and it was a total fiasco. They hated it. So either we kept going with it, or we had another choice, was doing it all over again, which we decided to do, and was how to crack 2 with the feedback of the people that we took into account. And we showed it again, and it worked. And the last step was broadcasting the video. But as you may know, crack is not legal in France, and it's not also legal to cook it. And the French government is more and more violent towards people with drugs. The prohibition is more and more violent, and the stigmatization is getting harder. So we told the funding internet, 1 minute, we're going to read. So the idea was we'll post an article and post it on the internet that we have the videos, and if you want them, you can ask us, send an email, and you'll get them. And so you can ask, if you want the video, you can ask them for the address info@federationaddiction.fr. So I want to come back to the first video because I think it's important to say, like, who knows what's good? Because you have the two pictures of the two videos, the first one and the second one. And honestly, for me, the first one looks better visually. And I thought it was. I thought it was great. The image was great. The production team was amazing. But when we showed it, people said, we don't feel this us. We don't feel it's scattered to our like identity. It's too clean. The background was white. It looks medical. It looks like it was made in a hospital. The tone was wrong. And so even if it was very beautiful, it didn't make sense for the people for which it was meant for. It was people with drugs and harm reduction worker. So we took that into account. The second version that you can see. So maybe less clean, maybe less, like the first thing is a clean, like a red sheet of paper to show the contrast. The second one is a piece of gin, the support. But when we showed that, it made more sense because people felt that it was them represented. So who knows what's good, the people it's meant for. And if they say it's not good, it's not good. So practically, what can you find in the videos? You can find 2 tutorials on how to cook crack, one with ammonia, the image on the left, and one with baking soda, the other image. So you can see the ammonia bottle. Harm reduction messages, we hire a visual team to do some like easy to understand like messages. For example, label your ammonia bottle, because if there is written ammonia on it, there is less chance of you ingesting it thinking it's a bottle of water. So very simple things, very trivial things, but this came from people who use drugs. Like I put ammonia on it to know. So the video was also about valorizing like knowledge, like the knowledge of people who use drugs, because it's oral things, like it's transmitted from people to people, is how harm reduction works. And the idea was also to valorize what people do in that they have to support themselves to survive. Things like eating, sleeping, drinking, because sometimes you forget to do it. And also information about risk and resources. So the idea was not to say like don't cook crack, don't use crack with ammonia, but there are risks. You have to know them. You do what you want with them, so you can have crack lungs. And also like there are risks you can reduce. And so, for example, you can check your product. So in France with the Analyse ton Prod network on analysetonprod.fr, and in Belgium with the TRIP project you can find on Facebook. And also it was the opportunity to explain that cooking crack doesn't purify the cocaine. And we did some testing. There should be, yeah. So just to conclude some lesson we will learn from the project. The first thing is start with people who use drugs. They know better. So when you start a project, the first person you need to ask for is someone who uses drugs. And for crack, not just someone who uses drugs, because sometimes we say like, we should use drugs, but like someone who really like that. So I would like to the government was really against harm reduction and those kind of things. But like we tried, we want to do this video because it makes sense, and we want to do this video and also a video on ammonia because we think it makes sense. And they say yes. And then they said like, what will you use? And they say like, we have to do it with cocaine. And they said, yes, okay. And then we said like, okay, we want to broadcast it. And they said no. So we went as far as we can. Like that's what the door blocked. Do what you can do with what you have. We didn't do a perfect video. We didn't show the whole way you have of cooking crack, but we had like this budget. We have like these resources, and we did like as much as we could. And it's important. Like doing something is always better than doing nothing. On thin ice, work fast, because those kind of projects are very like strict schedule. We never know when the government will change its mind, so we had to go fast, but don't rush because the first video was bad, and you could have said like, okay, we need to go fast, we need to like end this thing right now. but would have made sense. It wouldn't have made sense to do that. Share your ideas with partner, and great minds think alike. We have like lots of resources in the harm reduction field. For example, the structure in the north, they did this protocol. They share it with us. They could have said like, we want to keep our thing for ourselves. We want to be the one doing everything. But they said like, no, like it makes sense for you to do this video and share it. And then when we met the Moji Vivendi team, we could have said like, we want this to be a French project. We want this to be a Federation Addiction project. But it made more sense to like share ideas, share resource, and like harm reduction is a lot about solidarity and sharing things. Not syringes, but many things. And in the end, and with people with drugs, when you're done, you ask again, like, is it good? And if they say it's not good, it's not good. And if they say it's good, it's good. And so hopefully it's good.
Fantastic, Sacha. Thank you very much. As someone who was taught to freebase cocaine with ammonia by Dutch drug users and also taught a whole array of self-control strategies, we actually smoked cocaine on silver foil rather than in pipes because we understood the challenges of dose management. But I also have seen these campaigns around baking powder, and I really struggle every time I try to do it. And I think your idea of reaching out to ammonia users, helping us, and then also helping to try to move people to the healthier option of bicarb makes a lot of sense. So congratulations, really great project and lovely participation, which I always love. Great, so we're now going to go to Savannah O'Neill. Savannah is a consultant with Facente, there we go, consulting, a small values-based driven consulting company based in the United States. Savannah works on qualitative research and participant-centered needs assessment and supports the health and well-being of people who use drugs by supporting harm reduction programs. And she's going to be presenting recommendations from participants in a contingency management program in San Francisco, looking at the best practices from implementation and expansion. And look, contingency management is one of the models that's a lot talked about around promoting self-control and regulation and change around stimulants, and I'm really interested to hear more, Savannah.
Thank you so much, Matt. Oh, and then my computer just went off. Hi, everyone. I'm really honored to be on this panel. I'm learning so much, just how varied things are across the globe. So yeah, as Matt introduced, I'm part of Sente Consing, my two colleagues right over there, and I'm excited to be here today. I have a long history of doing direct service harm reduction work for the last 15 years in California and at the National Harm Reduction Coalition before becoming a consultant. So this is a kind of different presentation for me and for this panel, but I'm really excited to share. Oh wait, I got to do this too, huh? There we go. So since the drug supply is so different across the globe, I just wanted to briefly kind of let you know what it looks like in California and where I live, and San Francisco, where this project took place. So for over a decade, right, you all have probably known we're experiencing massive overdose crisis. It's the top 10 cause of death in California, not just accidental death, all death. And we lost 11,000 people last year to overdose in just the state of California. And fentanyl and methamphetamine are the most commonly associated with overdose. And actually, interestingly, since I was doing direct service work starting in 2008, we've seen a huge change, and we're starting to see more and more overdoses that are solely methamphetamine or are really combined with fentanyl. So we're needing evolving strategies and different things. So in San Francisco, the city, over half of overdose deaths had methamphetamine. There's been a lot of work to increase access to harm reduction services. State of California now is an active fleet in San Francisco. They're really limited treatments. There's been a lot put in low barrier access to buprenorphine and methadone for fentanyl use, but there has not really been access to things for methamphetamine. And there is just a lot of, as everyone said, stigma, judgment towards people who use both crack and methamphetamine and cocaine, and a lot of outreach towards those communities in the city of San Francisco and blaming them for a lot of things that are going on in the city. So actually, when I worked at National Harm Reduction Coalition, we did a survey of 500 people who use drugs throughout syringe service programs, And people who use stimulants wanted more support, right? They wanted support for psychiatric concerns, for overdose risk, for physical concerns that are associated with overamping, and just places they could rest. So the history sort of contingency management, which I'll explain for those of you that don't know, is actually it's existed in San Francisco since 2004, which is a long time compared to other places in the United States. But it was really initially intended for methamphetamine users and mostly men who have sex with men. So that was sort of the way it was formed, the clientele, how the program was structured. But because of all the things I said related to meth in California, there in 2023, actually our state public insurance decided to cover contingency management as the first state in the United States. So there was a big expansion and a lot of critiques of how Medi-Cal billing was going to do it. And so San Francisco actually has a more robust, more harm reduction approach to contingency management than what the state funds. And there's currently a dozen programs. So who knows what contingency management is in here? Okay, cool. We have a little bit of a mix. So I'm going to share with you because I want this to be applicable to you all. So really, contingency management, this is like the formal language, right? It's a behavioral intervention that uses rewards to increase a target behavior. So, and then it's used in conjunction with other treatment modalities. So you identify what is the behavior. So, right, initially this is conceptualized as abstinence from a substance. So someone wants to not use methamphetamine, wants to reduce their use of methamphetamine or stimulants, but it's also used for someone coming to counseling, someone taking their medications. I was just working with a program in a reservation in California that's using it to incentivize people just coming to the drop-in center and getting food. So you can identify any target behavior, even though historically it was abstinence from a substance. And then you provide a tangible reward really immediately after that behavior is achieved. So, they'll do urinalysis. If there's nothing in someone's system, you get a reward. Or if you come that day, you get something that day. It's not delayed. And the example of the reward structure is here. So some are like you get a weekly gift card, right? When you come in, you see your counselor, you give a urinalysis, you get a gift card. Or you come in and you don't do a urinalysis, you talk with the counselor, you get a gift card. There's also one where it's like a fish bowl, and so you reach in and you pick something. And so sometimes you get like an affirmation, which I'm like, I don't know, I would probably be bummed if I got an affirmation instead of a gift card, but it's kind of, you have a various things that you get, but they're all positive reinforcement. That's really the idea behind it. And then there's one, which is what most programs in San Francisco did, which is increasing awards. So basically, like if one week you get $5, and then the next week you get 10, and then 15, and then 20. So it's increasing the incentive for renewing behavior. So these are sort of what the programs look like in San Francisco. So I'll talk to you after I introduce this kind of about what we did with these programs, but there's over a dozen, and most of them in the city of San Francisco use the increasing rewards option. Most of them didn't do a fishbowl or fixed schedule, so most of them did that. They started between $5 and $10, and over the course of about 12 to 24 weeks, people could get up to $559. Every program that I talked to looked at non-reactive urinalysis, so for not having the identified substance that someone wanted to address in their system. Many programs also incentivized group or individual attendance. So if someone came, they're going to get a gift card no matter what. And then if they also have a target or a goal around their drug use, they would get that if they achieve that goal. The programs ranged, there was one that was 5 sessions that was a mobile program kind of further out, but most were 12 to 24 weeks. And the current kind of issue is that they're only available to people who are currently clients. So I talked to a couple methadone clinics that are now doing this with people who are using stimulants, or a syringe access program that does it, but they're not kind of freely available to anyone who wants to do it. And the capacity ranged from like 6 to 100 people. Every single program involved individual counseling, linkage to care, and naloxone access. Most involved food, coffee, other comfort things. 2 groups also did group programming, and that was like a very huge success in the programs that did that. So what did we do to talk to folks? So Facente Consulting was brought on by the San Francisco Department of Public Health to seek the expertise of people actually in these programs, right, to inform how they're going to expand. And that's something that's really important to our approach when we do this work. As we've heard, right, you need to talk to people who are actually in the program using stimulants, wanting to change something about their stimulant use to know what the program should look like. So we did focus groups and interviews with over 50 people from 10 programs. And we also did some surveys and interviewing with providers who work in those programs. And we then systematically analyzed the data and came up with themes and recommendations. So that's what I'm going to go into today. So what did we find? So I normally talk really fast and I'm nervous about time. So I'm going to try to make this not rushed. So this was by far, over and over again, the most consistent takeaway. And as someone who has a lot of critiques of drug treatment, this was really profound for me. So people really appreciated the positive focus on rewarding behavior change. It really contrasted with their other experience of any treatment settings that they'd been in, where they might be kicked out for a return to use or feel punished. So you can see someone said, I've explained it to different types of people. It's like the opposite of when you drug test in other places. Instead of being punished for the negative, you're incentivized for the positive. And it's encouraging in that rather than demonizing. And I really personally was like, I don't understand how a UA could not feel stigmatizing and terrible. That like, when do you give UAs, right? In all kinds of punitive systems. And that just really wasn't people's experience of doing this. And I think that has a lot to do with the culture, the staff. So I think that could not always be true. But what we found is that people really felt positive about it. Also, that giving people money is helpful. That the rewards confer many layers of value. That people said, you know, on a day where maybe I wouldn't show up, I'm having a bad day, I feel like shit. That money, that reward got me out the door. And then I kept engaging. It made a difference materially in people's lives. It supported well-being, self-reliance, self-worth. And it again reframed the relationship to treatment as positive. Shelly and I heard a lot about Burger King. People were really excited to buy their own food at Burger King. But I mean, really, it was about people being able to buy their own meal, buy their kid gifts. One guy sending Christmas gifts home to Guatemala. A lot of people were saving up. You can also like bank it. So people would save up to like buy tool sets to be able to work afterwards. So there was just a lot of positive things that the money gave. But what was interesting, this wasn't actually the number one thing. So I mean, one of my takeaways is like, actually, it's about harm reduction spaces that treat people well and don't penalize people. The first thing was what people mostly cared about, but this was also helpful. So, you know, again, non-judgmental, welcoming, and trusted spaces were key. The people really emphasized how the non-judgmental space, especially when people continued to use, there were some people who did the entire 24-week program, wanted to do it again, who only gave UAs with methamphetamine in them. And they still wanted to keep coming to the program for counseling, for the group support, for other things. It really, you know, having that community building space, snacks, coffee was really important. And keeping the same staff, right? We all know when you go somewhere and every time it's a different person, you don't know them, that is not going to be as supportive. So really investing in trusted staff was huge for people. And they said, you know, people let us be honest. We don't have to just be strong, and we accept people who use drugs. The staff are people who understand us and don't look down on us. And a lot of them were people with their own lived experience, but not exclusively. And again, the need for programs that focus on more than abstinence, right? So providers emphasize the importance of models that were across the spectrum. So health insurance and are only incentivizing you for abstinence. And we realize that there's really a need to incentive kinds of positive behavior change. And it may allow us, like we talk about with all harm reduction, right? It's about increasing support for people, allowing us to reach a broader population, to engage them in a full continuum of behavior change and treatment, and address overdose prevention, other related harms, safer drug use information. So yeah, narrowing it to the small population of people who have a goal around abstinence just was not as meaningful. And again, pretty straightforward. People want to be involved in planning programs. They want to help decide what it looks like. They want to not just be asked at this phase, right? Kind of to Sasha's point, it's like, okay, cool, you asked me, this feels so good, thank you. No one's ever asked me what I think treatment should be like. but like, are you ever going to come back? Like, what is going to happen to all this information? So they want to be involved in an ongoing way. So one of our recommendations to the health department was to create a mechanism for ongoing input. And they were like, the idea that we're able to graduate this program, our words and thoughts should be more valued than other people, especially than doctors, which I imagine many of us can agree with that. Then the other one was the opportunity to co-locate programs. So like I mentioned, 2 of these programs were housed at opioid use treatment programs, and they really described huge success and sustained engagement when people use stimulants. When I was very young, worked at a methadone clinic, and I had a lot of people who were stable on methadone, but continues to use stimulants for decades, some of whom really didn't want that to be true. And housing those 2 things together made a huge impact. I know I met one woman who was like, this is the longest period I've ever been off stimulants in my adult life. And I think having those things together was really powerful. And then again, co-location ideas parallel other patient perspectives. So different people said, what if put it in a housing program or an SRO in the clinic where I already have that relationship? And so these are kind of some specific barriers, but for those of you in programs, I thought they could be interesting and helpful. One thing was that people said stimulant or contingency management can be complicated for people who are on stimulants. So if you're prescribed Adderall, Ritalin, other kinds of stimulants, it can be more complicated than like on point urinalysis testing to make sure that someone can actually prove their goal. Attendance is really important to these programs. People come twice a week, right? It's part of attendance. It's part of getting the reward regularly. And that can be tricky if you have holidays or closures or natural disasters, just like that can lead to interruption in momentum. And it's challenging to find good staff who can adhere to actual harm reduction based contingency management best practices. And there is a need to really invest in that. And again, currently in the state of California, the cap is 24 weeks, which is just too short for a lot of people to benefit. People really wanted to keep coming. And I met many people who did keep coming, but they weren't incentivized at that point. And also the health department in San Francisco is adding additional money in addition to the Medi-Cal reimbursement to be able to do these more robust, low barrier options. So these are just some recommendations that kind of echo what I've already said, but I'll run through them quickly for those of you who are interested. Basically, continue to expand additional locations, mobile services, broader hours of operation. Really focus on models that don't only include abstinence, that are across the spectrum of harm reduction, and including some tailored models. So kind of creating partnerships with orgs that either reach out to people based on race, neighborhood, gender identity, other groups. People really felt like a sense of community in these groups and spaces. And so how do you create that and like sort of make them unique based on what people need? Just fund people more to be able to provide a robust array of services, including group programming, and prioritize funding to really keep and sustain strong clinical staff and counseling, right? That's what makes the program is how people are treated. Which is depressing that one of our number one takeaways is like, people treated me so well. But that's true. And then to create opportunities for mentorship and training for new people to get involved in this work, expand the length of time, allow it to be longer than 24 weeks. Expand the reward options, right? Don't only have gift cards, or include a variety of gift cards so that people can choose. Cash would be great. We talked about that a lot. Funding for survival needs, foods, comfort items. So just having a more, a way that people can actually really choose what they're going to do with what they earned. And create opportunities for aftercare. And again, meaningful involvement in the program design in an ongoing, meaningful way. That's it. Thank you.
So thank you very much, Savannah. Really fascinating discussion. I think really helps for me understand some of the differences around contingency management not being used as this very punitive tool, but actually being used as something that is seen as empowering. And yeah, lots of takeaway thoughts for me on that. Thank you. And we'll come back to questions when everybody's finished speaking. So we now come back to the region. So we are going to hear from Carolina Gómez, who's going to be speaking about harm reduction strategies in cocaine use, from qualitative insights to scale development. Sorry, everything's turning off. And let me tell you, she's director of the Drug Use, Public Health and Education at the Centro de Estudio Sombra, I'm going to destroy that, in Colombia, an interdisciplinary research center that promotes broad and informed debate on security and drug policy in Colombia and Latin America. The work is focused on harm reduction in prison settings, lifelike contexts, and psychotherapy. She's currently completing her doctoral dissertation on harm reduction strategies among people who use cocaine. So, Caroline, I'm really looking forward to hearing from you. Can we have the pointy stick thing? So much.
Gracias. Yo voy a hablar en español y les voy a pedir una disculpa porque voy a leer. Quienes me conocen saben que cuando estoy nerviosa hablo súper rápido y como sé que muchos de ustedes están usando el traductor, pues no quiero ponerlos en aprietos. Bueno, quiero empezar por decir que el mundo vive un momento crítico con respecto a la cocaína. El consumo está en niveles sin precedentes, al igual que la producción. En 2022 se fabricaron más de 2.700 toneladas de cocaína en el mundo. Eso es un 20% más que el año anterior y el triple de lo que se producía en el 2013. La demanda crece y con ella las consecuencias. Para ese mismo año se estima que 23 millones de personas consumieron cocaína y aunque en América Latina hemos sido tradicionalmente catalogados como países productores y de tránsito, la realidad es que una cocaína de alta pureza a bajo costo ha aumentado el consumo y la evidencia sobre lo que pasa aquí es escasa. Alrededor del mundo los daños de la cocaína son múltiples. Además de toda la violencia que sufre nuestra región asociada a la producción y el tráfico, también aumentan las hospitalizaciones, la demanda de tratamiento y las muertes. Aunque existe evidencia que respalda la efectividad de algunas intervenciones terapéuticas, su alcance sigue siendo limitado, pero sobre todo no llegan a quienes más lo necesitan. Además, muchas siguen centrándose principalmente en la búsqueda de la abstinencia y es escasa la investigación sobre cómo las estrategias de reducción de riesgos y daños, especialmente aquellas que se usan en el nivel individual, pueden consolidarse como una estrategia costo efectiva. Estudiar estas estrategias de reducción de riesgos y daños resulta crucial, especialmente en un país como Colombia, donde hoy estamos convencidos de que solo seremos capaces de dejar atrás la violencia a través de una regulación responsable de la cocaína. Yo soy Carolina Pinzón Gómez, dirijo el área de salud pública, educación y consumo de drogas en el Centro de Estudios sobre Seguridad y Drogas de la Universidad de los Andes y junto con otros colegas de la región, Clara y Miguel, que me acompañan también hoy, pues hemos decidido cómo podemos con intervenciones de reducción de riesgos de daños específicamente para las personas que snifan cocaína, que aunque de pronto es un tema que no puede ser muy interesante en otros países del mundo, para nosotros como región resulta crucial, sobre todo en cuenta que es una de las sustancias que tiene una mayor prevalencia, incluso por encima de las cocaínas fumables. Nos sirviera para evaluar la efectividad de las intervenciones y entender mejor los vínculos entre el consumo y las consecuencias negativas y así poder diseñar respuestas más pertinentes y eficaces. Lo primero que hicimos para indagar sobre estas conductas de reducción de riesgos y daños fue una revisión de literatura. No encontramos mayor cosa, mucha literatura sobre los daños, pero casi nada sobre cómo prevenirlos, más allá de la abstinencia. Nuestra segunda estrategia entonces fue revisar de manera amplia las recomendaciones que las diferentes organizaciones de reducción de daños en Latinoamérica brindan a los usuarios de cocaína. Sin embargo, aunque suponíamos que estas estrategias se habían construido a través de la experiencia de los propios usuarios, tampoco teníamos información sobre si estas estrategias realmente se relacionaban con una disminución de las consecuencias negativas del consumo. Entonces decidimos realizar un estudio cualitativo exploratorio. En este estudio participaron personas adultas hispanohablantes que consumen cocaína por vía esnifada. Hicimos con ellos entrevistas semiestructuradas a profundidad. El reclutamiento lo hicimos a través de muestreo por conveniencia y por entrevistas realizadas en entornos seguros y confidenciales. Para el análisis de datos hicimos un análisis temático inductivo para identificar patrones y categorías emergentes. Los hallazgos de nuestro estudio revelaron 12 categorías de estrategias. No me voy a detener mucho en estas, les voy a mencionar solamente algunas y también me gustaría poder rescatar como algunos de los apartados de estas cosas que los usuarios de cocaína nos contaron durante las entrevistas. La primera categoría tiene que ver con la evitación del consumo, es decir, cómo los usuarios toman decisiones conscientes sobre en qué momentos no deberían consumir porque podría considerarse una situación de mayor riesgo. Por ejemplo, un usuario nos decía, no la consumo si estoy solo. Otra categoría son las estrategias de distracción que tienen que ver con que buscan hacer otras cosas para poder manejar el deseo o el craving de consumir. Luego otra categoría tiene que ver con cómo se preparan para el consumo, es decir, las conductas de planificación para evitar tener riesgos durante el consumo. Otra categoría tiene que ver con la evaluación de la calidad de la sustancia, en la que nos contaban qué estrategias utilizan para saber si, por ejemplo, la sustancia es de mala calidad o está adulterada, y en esta un usuario nos decía, es muy difícil saberlo a menos de que acudas a un servicio de análisis. Lo que hago yo es tener a alguien en quien ya confío, en eso nunca me ha ido mal. También encontramos otra categoría de estrategias durante el consumo, que tienen que ver como en el entorno y las decisiones que se toman durante el consumo para prevenir esos riesgos. Una categoría sobre el cuidado de la vía de administración, que tiene que ver no solo con qué vía de administración eligen, sino también qué estrategias utilizan para cuidarla. Y aquí, por ejemplo, un usuario nos decía, los billetes son más sucios, las llaves también, aunque se pueden desinfectar. Otra de las categorías tiene que ver con el manejo de la dosis, que pues significa cómo ellos se administran durante un tiempo, cierta cantidad, con cierta frecuencia la dosis, en función de cómo se van sintiendo. Y aquí alguien nos decía, pues ves cómo te pegas, si no es muy fuerte, si es muy fuerte, te paras ahí hasta que baje, y si es muy suave, pues tomas un poco más. También nos hablaban sobre el cuidado con las mezclas, evitar combinaciones peligrosas, por ejemplo. Si tomo otro estimulante, intento reducir un poco los dos, porque si no pega muy fuerte y es muy incómodo. También nos hablaban sobre el manejo de posibles eventos adversos o efectos adversos, como el mal viaje, y alguien nos decía, entonces, mantén la calma, sal de la fiesta y si puedes, respira. Hablaban también sobre la reducción de riesgos sexuales, que tiene que ver con cómo se preparan en estas sesiones de consumo y llevan con ellos métodos de barrera para prevenir la transmisión de infecciones de transmisión sanguínea, por ejemplo. Y por último, también nos hablaban de cómo prevenían problemas legales, por ejemplo, cómo escondían muy bien la cocaína para evitar tener, digamos, encuentros con la policía. Y por último, nos hablaban de estrategias posteriores al consumo, es decir, qué hacían después para recuperarse de una sesión de consumo. Aquí, por ejemplo, alguien nos decía, descansa, intenta dormir aunque no tengas sueño, intenta comer aunque no tengas hambre y bebe mucha agua. ¿Qué hicimos entonces con esta información? Primero generamos una lista inicial de 85 estrategias que luego se depuró hasta obtener 56 ítems. Algunos, por ejemplo, de los criterios que utilizamos para depurar esta lista era contrastar que estas estrategias que ellos mencionaban pudieran realmente estar respaldadas por la evidencia. Y un ejemplo aquí importante es que algunos de ellos nos decían que para verificar la calidad de la cocaína, lo que hacían era probarla un poco, olerla o ver si su color era diferente. Que hoy en día sabemos que pues, puede ser una estrategia no muy efectiva, sobre todo si hablamos en un contexto en el que haya, por ejemplo, fentanilo, que no huele, no sabe y no se ve, ¿no? Luego de hacer esta depuración y quedar con estos 56 ítems, lo que hicimos fue evaluar estos ítems por unos jueces expertos, pero también por las propias personas usuarias de cocaína para garantizar la calidad, pertinencia y coherencia de estos ítems. Con esta información se construyó un instrumento, una encuesta en línea que incluyó los ítems de estrategias de autocuidado, pero también incluyó algunos datos sociodemográficos, algunas preguntas sobre patrones de uso y un cuestionario sobre consecuencias negativas asociadas al consumo de cocaína. Esta encuesta se la aplicamos a 550 personas hispanohablantes que reportaron consumo de cocaína por vía esnifada en el último año. La muestra fue diversa, con participantes de 16 países, pero especialmente participantes de Colombia y México. Y para el análisis utilizamos un análisis de componentes principales para identificar una estructura factorial. Sí. A partir de esto se obtuvo una solución de 7 factores con 24 ítems que explicó el 36.8% de la varianza del modelo y que reflejó dimensiones claves como el cuidado físico, la dosificación de la cocaína, la evitación a la detención del consumo, la planificación de la sesión, la reducción de riesgos sexuales, la detención del consumo durante una sesión y el cuidado de la vía de administración. La escala mostró una alta consistencia interna con un alfa de 0.84 y con subescalas sólidas. Pero lo más importante es que el uso de estas estrategias se correlacionó negativamente con la frecuencia de consumo y con las consecuencias negativas reportadas, apoyando la validez de la escala como una herramienta para identificar prácticas protectoras. Una de las principales conclusiones que se derivaron de este estudio es que el concepto de estrategias conductuales protectoras, como se conoce en la literatura, se quedaba corto para definir lo que estábamos encontrando, puesto que estas estrategias iban más allá de meras estrategias conductuales. Por esta razón decidimos llamarlas estrategias de reducción de riesgos y daños, para simplificar el lenguaje, pero también porque consideramos que es importante llamarlas como lo que son. Y, en función de esto, decidimos entonces definir las estrategias de reducción de riesgos y daños como múltiples estrategias que pueden ser cognitivas, pero también conductuales, que emplean las personas antes, durante y después del consumo para reducir, detener o prevenir los riesgos y mitigar los daños asociados a ese consumo. Y para finalizar y concluir un poco, pues, ¿de qué nos sirve esto o para qué nos sirve esto? Lo que encontramos es que con respecto a las intervenciones, esta escala puede ser de utilidad para identificar perfiles de riesgo y diseñar intervenciones personalizadas para las personas que consumen cocaína. Además, facilita el seguimiento del uso de estrategias de cuidado en los usuarios que no quieran o no puedan dejar de consumir. También puede integrarse con intervenciones breves, en intervenciones digitales o en procesos educativos comunitarios. Y por último, le brinda a los profesionales de la salud una herramienta para trabajar desde el enfoque de reducción de riesgos y daños. Con respecto a las políticas públicas, creemos que una escala como esta puede establecer un marco válido para evaluar la efectividad de algunas intervenciones de reducción de daños para las personas que consumen cocaína. Además, aporta evidencia empírica que respalda la ampliación de las intervenciones de reducción de riesgos y daños, sobre todo pues este enfoque no basado en la abstinencia, pero además consideramos que nos sirve para visibilizar las prácticas de autocuidado que ya existentes en las personas usuarias de cocaína, que puede traducirse también en la desestigmatización de las personas que usan drogas. Por último, creemos que podemos utilizarse para diseñar materiales educativos y para medir los cambios en el tiempo y así poder sustentar las decisiones de políticas públicas basadas en datos. Muchas gracias.
Thank you very much, Carolyn. A really, really interesting and thoughtful presentation. What an interesting session we've had, from piping to contingency management to washing up and then to looking at people snorting. I want to open up the floor to give anybody a chance to either ask questions or comments. So let's go here first. Can someone take a microphone?
Hola, buenos días. Yo soy Chica de Brasil y yo quería saber dónde podemos, where we can find the video, the address. I'm really curious to see this video, and I would like to share with you guys experience of São Paulo, Brazil. Ernesto was talking about the pipes and how it's important for us to get beyond the pipes to take care of people who use crack. In São Paulo, in 2022, we had a really big police operation in downtown to try to finish with drug trafficking. And one of the stages of the police intervention was to arrest people that have pipes on their hands. And in 2 months, the police arrested around 800 people that were with pipes in their hands. And these people, they went to the police station because they only had a pipe. That is not a crime to have a pipe. These people had to, in the police station, were offered to them hospitalizations. And the police said, if you don't accept the hospitalization, you will stay arrested here in the police station. So the police station, for a few months, were the waiting room for the healthcare, you know. So it was like it all started with the arrests because the people were carrying pipes, and after that, the justice of the state of São Paulo, I don't know how to say in English, annulled, I don't know, most of the arrests because it was not a crime and people did not have drugs with them, only pipes. But the pipes still are a tool to stigmatize, to produce violence, and to selectively offer some people on the streets that are with pipes. So the pipes have important plot in this context.
Thank you very much for that. There was another comment here. I'm just going to keep the audience talking rather than us.
¿Aló?
Please.
La voy a hacer en español. Y esta va para todos los panelistas porque cada uno se desarrolla con diferentes drogas. Primero quiero comenzar expresando mi más sincero agradecimiento y reconocimiento a HR25 porque este año por primera vez se ha abierto el espacio para la reducción de daños del tabaco. Para nosotros esto no es solamente un gesto, es un acto de esperanza, es el primer paso hacia una visión más amplia, más justa y más inclusiva en la reducción de daños. Considerando que las tasas de tabaquismo más altas que existen en el mundo son de los usuarios de drogas duras, quienes no lo saben, el 90% de los usuarios que consumen drogas consumen tabaco. ¿Ven posible que en las estrategias de reducción de daños se incluyan explícitamente también el acompañamiento en reducción de daños del tabaco, pensando que el 60% de los usuarios de droga van a morir por culpa del tabaco?
Great, thank you very much. So highlighting the need to do parallel work with different smoking issues that people find issues in their life. So we're now going to go to our friend here.
Sí,
Anyone
gracias.
else, put your hand up if you want to go.
Felicitaciones a todos, excelentes presentaciones. Mi pregunta es sobre el policonsumo en relación con la cocaína. Una práctica que yo he visto relativamente frecuente es que en usuarios de cocaína se suele usar también posterior al consumo de cocaína drogas depresoras para, digamos, lograr el bajón y poder dormir y esto. Entonces, creo que algunos usuarios consideran que esta es una práctica relativamente de reducción de riesgos, reducir el riesgo de no dormir, de no descansar, reducir el riesgo de seguir consumiendo más por la ansiedad. ¿Cuáles son los riesgos de combinar un estimulante como la cocaína con depresores como benzodiazepinas u otros? Gracias.
Great, very, very important issue. So we'll come back to your reflections just at the end, but picking up this particular issue of sleep, we understand that for people using stimulants, sleep deprivation and not eating are two really critical factors.
Hello, my name is Bob. I'm a gringolombiano. I lived 60 years in the States and the last 10 now here in Colombia. So I identify now, try to be sensitive to both cultures. Just a thought about including people with lived experience, whether it's dealing with harm reduction with people with mental health challenges, or harm reduction with people who use drugs, or harm reduction with people who are the victims of injustice, how important it is to include their voice in any harm reduction programming. So I like to say the phrase, I borrowed this from Judy Chamberlain, a pioneer in mental health in the United States, nothing about us without us.
Great, thank you very much. Yeah, I'm currently the community principal investigator on Professor Magdalena Harris's study into the safe inhalation pipe provision project in the UK. Very important that we've got a community principal investigator on the study, but that also there's like peer engagement alongside service engagement, because you often get quite different populations at different points in the engagement. So thank you, Bob, that's great. Right, final round before I go back to our speakers to give some closing comments. Anybody else want to say anything else? Right, let's go back in the order that people started speaking in. Ernesto, back to you, my brother.
Gracias. Does everybody speaks English? So it might be easier for the answer to be in English. See? Beautiful. So starting with Tika, thanks for the comment. I don't think I have much to say about that besides policing, how drug policy affects more. It makes more harm than drugs itself. So how to change that, how to readdress, and that's why I think definitely harm reduction goes much beyond sanitary intervention. It's an advocacy. It's a political and militant compromise. Did you say that? Yeah. All right. So about tobacco harm reduction, first of all, I think there's no hard drugs. There's just drugs. In fact, we think which drug produces more damage. We think it's alcohol. So we definitely think, I'm a cocaine user myself, and I love to smoke when I use cocaine, especially menthol cigarettes. Now with vapes, that it's more menthol, I've been changing, so I do definitely think there's a need to address, because many of us drug users, especially who use stimulants, also enjoy smoking. About Aldo's question on benzos, myself, I don't like benzos. It hits me too hard the next day, but sometimes I do need, but I tend to wait a little bit when it drains out the stimulant effect. What I do is I try to use other strategies that Carolina showed. In fact, I was one of the person interviewed in her research. I try to breathe, take a shower. Well, Matt knows that a lot. I'll get to that. But also get into a dark space, close my eyes, even though I cannot sleep. My brain, all of our brain needs some hours of complete darkness. But I do think alcohol, it's a big issue also. Most of us who use cocaine also drink a lot when we use cocaine. And that's, I think, a bigger thing to think about, because how the component between alcohol and cocaine gets, so the cocaetileno thing, and that affects your liver even more. In Voices of Lived Experience, I'm completely into it. In fact, Matt, I would say he's one of my mentors. He's been working on stimulants for decades. The whole training on stimulants that we've been trying to translate to Spanish and bring to Latin America, it's starting in Brazil, if I'm not wrong. This is also funded by UNODC. So we also have guidelines from UNODC for stimulant users in HAB, and written by people who use drugs. So definitely, it's indispensable to be part of it. And just like that.
Gracias. Bueno, con respecto a la primera pregunta sobre tabaco, pues voy a responder desde el área en el que yo trabajo, que es el estudio de las conductas de reducción de riesgos y daños. Creo que esta metodología que utilicé para investigar el consumo de cocaína y que se ha utilizado para investigar también sobre el consumo de alcohol y de marihuana, pues es útil para investigar sobre el consumo de cualquier sustancia. Lo que creo que es importante ahí es reconocer que los usuarios de, en este caso, tabaco, pues han desarrollado quizás de manera intuitiva, pero también desde la experiencia, algunas estrategias que les permiten disminuir las consecuencias negativas del consumo, y que lo que es importante ahí es que podamos nosotros de manera sistemática indagar sobre esas estrategias, pero también sobre cuáles de esas estrategias realmente se relacionan con una disminución de las consecuencias negativas. Creo que es una metodología que se puede utilizar con cualquier sustancia, y seguramente también vamos a poder encontrar mucha información sobre qué podemos hacer para reducir los riesgos y los daños asociados al consumo de tabaco. Con respecto al tema de las mezclas, creo que es uno de los temas como complicados que se hablaron mucho en las entrevistas, como en esta parte cualitativa y exploratoria. Y es que sí, justamente muchas personas hablaban sobre efectos negativos o que consideraban incómodos, sobre todo cuando se sentían sobreestimulados por el consumo de la cocaína y que encontraban en consumir otras sustancias como por ejemplo el alcohol o las benzodiazepinas una forma de balancear esos efectos y de alguna manera pues como calmarlos. Lo que también encontrábamos es que eso al final se traducía en que sentían una mayor capacidad de consumir más y en esa medida, pues al aumentar la dosis de ambas sustancias, pues se incrementan los riesgos del consumo de ambas sustancias y ahí entonces lo que creo es que es muy importante que podamos trabajar en la psicoeducación, ¿no? Y en cómo, por ejemplo, las personas pueden aprender estrategias para conocer bien cuál es la dosis que pueden consumir para evitar llegar a ese punto como de sentirse muy estimulados y necesitar consumir pues como una sustancia que les ayude a balancear. De todas maneras, digamos que siento que es un asunto como muy particular y que depende mucho como de las personas. Efectivamente, si hay una persona que está atravesando por un evento adverso como una crisis, de pronto un ataque de pánico asociado a la excesiva estimulación, pues definitivamente lo mejor que puede pasar sí es que le receten benzodiazepinas y ojalá esto pues sea en un entorno pues clínico. Pero a lo que voy con todo esto es que creo que es importante y sobre todo en este asunto como de las estrategias educativas que las personas que trabajamos en reducción de daños podamos educar a los usuarios o educarnos entre los usuarios sobre la importancia de conocer, por ejemplo, las interacciones de las mezclas, los riesgos que asumimos cuando decidimos mezclar unas sustancias con otras. Y por último, con respecto a la pregunta sobre la participación, pues sí, creo que es un componente clave de esta y de cualquier investigación. Creo que el primer reto que yo encontré cuando quise iniciar esta investigación fue el no encontrar información, digamos, basada en la evidencia científica sobre estrategias que las personas pudieran usar para disminuir los riesgos. Y esas estrategias, pues claramente la mejor forma de conocerlas era a través de los usuarios preguntándoselas, digamos que un poco apartándonos también de otra visión que hubiera podido ser alternativa, que era la de ir a un laboratorio y hacer que las personas consumieran sustancias y ver cómo podíamos disminuir esos efectos negativos y etcétera. Es decir, qué mejor que la experiencia de los propios usuarios para ver ellos qué hacen y qué les ha funcionado. Y sí creo que ahí la investigación puede jugar un papel clave, que es el de poder encontrar si realmente existe una relación entre esas estrategias que a veces intuitivamente implementan y una disminución de las consecuencias negativas asociadas al consumo.
Thank you so much. Sacha?
Thank you. So to answer the third question, the first one where I find the video, it's at infos at federationaddiction.fr, but I can just write it on the things and maybe put it on the app of the conference. And it's funny you say that I was Sao Paulo because in France last year there was in Paris a prefectural thing, a district thing that said that people who crave crack are not allowed in some part of Paris. So let's define craving crack. It also means they don't use crack at the moment. So that's a funny thing. About tobacco, yes, it's important. Also, cannabis, everything that's smokable, and we have a very useful harm reduction tool that is vaping. It works very well, and we could imagine vaping for crack. Actually, would make sense for the damage on the lungs. The question about benzodiazepine, yes, it was a thing we saw in the EPOC project, and with the harm reduction guide when we included that, because we need to start with what people do, and if people do use benzodiazepine, it works as a form of harm reduction, and so we just need to work around that and like give information about the risk that can exist and how to reduce them. So, for example, the risk of addiction, how to like maybe find other ways to relax after a session. And about the nothing without us, nothing about us without us, as I said, like the video would have makes any sense if people with drug was involved. It would just have been something for like doctors in the hospital to just know what cracks look like, and wouldn't have been very useful.
Thank you. I don't think there are any questions for me, but I will give a closing statement unless. Oh, sure. That wasn't a prompt, but go ahead.
Thank you for all your presentations. Special thank you to you that you're doing things in Colombia. I'm Colombian. I work in New Zealand. I'm a primary care physician. And I'm doing addiction medicine. One of the biggest things that we have in New Zealand is methamphetamine use. I cannot stop it. I cannot, my majority of my opioid substitution treatment patients are on meth. But what I'm seeing is this increasing amount of young people with severe heart failures. And often they say to me, I wish I knew that heart failure, that was going to be, that the continuous use, people start using when they are 15, and I see them when they're 25, in the 30s, that are on all these medications that they don't comply with. I had somebody with taxubo cardiomyopathy, even, with dissecting aortas. Is there anything about harm reduction that we can educate our clients about the cardiovascular disease risk that they are seeing? I'm seeing blood pressures of 220 in a 20-year-old for a systolic. So to give you an idea, normal blood pressure is 120. So I don't think we're talking about this. And I'm really, really concerned because when they go to hospital, I ask them, the majority of people don't say anything. They have heart attacks that they don't respond to GTN, so they continue to destroy the myocardium, the heart muscle, and I don't see the messages, and I'm really worried.
Yeah, I'm sure we all would have something to say on that. Do you want to share something? Okay. Yeah, I mean, just to respond to that briefly, I think that I definitely see that, and I think one of the things I was going to start with is what an honor it is to be up here. And also in the United States, at least, we have been really focused on opioids, which, I've lost lots of people to opioids. It's obviously lots of stuff we can do to reduce harms of people who use opioids, but stimulant use has been way less centered, funded, discussed. And the health impacts that, for people who long-term use stimulants are still very important to manage. So for me, it's been about, having good providers who people trust. And one of the things I was going to say is how absurd it is that one of my points is people treat people well and we include people. Those should not be fucking new ideas. And if we had treatment systems where people could talk about their health concerns and not be worried about losing their kids, not being able to go back to the hospital, stopping their Adderall medication, then we would have people be able to talk about their health issues differently. And I think more specifically and less philosophically, right? I think there is a lot we can do around harm reduction strategies for people's physical health. And I think it's about educating people, creating spaces for people to get that information, videos, having accessible ways for people to learn about that. Because, I have a lot of friends who I met through harm reduction who had used drugs for a long time but not done this work formally that were no one ever taught me that, right? And I've been injecting drugs for 15 years and you're teaching me that, and I'm not an injection drug user. So I think we have to create spaces for those conversations. But thank you all, and I'll let other folks respond.
Okay, so I'm just going to wrap us up. So look, I run the UNODC training course on stimulants, and one of the key points we make in that training is, look, now, as someone who uses both stimulants and opiates, now I can use opiates throughout my whole life without doing fundamental damage to my body beyond the issues of dependence and the issues of injecting, but the actual drug itself isn't going to be fundamentally destroying my body. If we don't manage dose and sleep and other issues with stimulants, we will damage our hearts. We will have strokes in our 40s and 50s. As a 58-year-old cocaine user who's been using for 30 years, that's not an automatic outcome, but the vast majority of people are not taught how to use stimulants. Criminalization drives us towards rapid using, which is often piping, whereas I was taught to chase. No, we layered up our dosing. We used cocaine first, then heroin, and then finished with heroin. No, that helped us keep our dosing down. We used in groups, so the foil went round, so it kept your dosing down. And you understood that if you didn't do that, I lost control on crack for 3 years. And let me tell you, when it catches you hard, it really catches you, and that's a really fundamental thing. But I don't think we should be denying this issue of health issues that go with stimulant use. They are very, very real. It's why I think we should have much better stimulant pharmacotherapies. And I think I think it'd be very interested to have a conversation with you around how we develop that stuff.
And
yep.
And
And,
it's
just to say finally, my card is here at the front. If you'd like to know more about the UNODC training course or join the trainers course, there is also something called the Stimulants Experts Group, coordinated by Harm Reduction International, which is an e-list for people working on stimulants. Please take my card and I'm happy to introduce you. Thank you all very much for the session. Thank all our speakers.